Thank you, Mary. It's a great honor to be here, and I thank the organizers of the course for inviting me. Since I had a 50-year career at the Children's Hospital of Philadelphia dealing with the challenges of childhood brain tumors, they perhaps thought I knew something about the subject. My career started at the University of Minnesota Medical School in September of 1953. The dean of the medical school had some words of welcome to the incoming class. And among other things, there were a few comments that made an indelible impression upon me and which have actually guided my career subsequently. Basically what he said was that over the next 4 years, we were going to be expected to learn a tremendous number of facts and develop concepts. But we should keep in mind that over the period of our career, some of those facts that we were being taught and were expected to learn would change, so that advancing knowledge would obliterate some of the things that were important. And the important thing that we as medical students should keep in mind was that we should have an attitude toward learning which allowed us to accept new knowledge as it came forward. So I would like to use that concept and that plan to review the situation of brain tumors in children, and I'm going to do this from the historical view, and I'm going to give you a journey from the earliest classification of childhood brain tumors to those that are currently in use. And the basic premise of my talk is that the tumors have not changed over the years. What has changed has been our ability to discern the unique diagnostic features by applying new techniques as they became available for their diagnosis. And a historical review, I hope, will establish the foundation of the premise that I hope that you will accept by the end of the presentation. The beginnings, of course, go back to Rudolf Virchow, who is the father of cellular pathology, who in 1858 published a book, and the basic feature of the book and his ideas were that cells come from cells. And he pointed out that the microscopic study of cellular composition of organs held the key to an understanding of health and disease. And here's Professor Virchow. In addition to this concept of cellular pathology, he identified glia, which for neuropathologists are extremely important because they form a major part of the central nervous system and also of many of the tumors with which we have to deal. Now, the issue of classification of brain tumors really was not terribly important for clinicians. It was really an academic exercise for pathologists until Harvey Cushing and his colleagues in England and Switzerland in particular developed the techniques to allow neurosurgical procedures to operate on the patients who presented and who were thought to have brain tumors and to remove those tumors. And over a period of years, it was Cushing's idea that the prognosis of the tumor was related to the tumor histology. Cushing started out at Hopkins, and then he went to Yale, and finally went up to the Brigham Hospital in Boston. And at the Brigham, he had a pathologist by the name of Bert Wolbach. This is not Wolbach. Wolbach's interest lay in other organs of the body. He had no interest whatsoever in central nervous system pathology, and in particular in tumors. One of Harvey Cushing's pupils early in the 20s was Percival Bailey. Percival Bailey came to study the art of neurosurgery, and Cushing had a rather low opinion of Percival Bailey's expertise in the operating room. And his frustration with Dr. Wolbach had reached such a point that he finally decided he needed to have somebody study the tumors upon which he had operated. And by the early 20s, he had accumulated about 400 specimens. So what he did at that time was establish a laboratory and assign Percival Bailey the task of looking at these tumors, diagnosing them, and establishing some kind of a classification system. The entire story of the origin of this classification has been reviewed and published by Orville Bailey, in no way related to Percival Bailey, and it's published in Pediatric Neuroscience. And it's a very fascinating story. Most of the details I can't give you, but I'll give you some of the high points. By 1922, Bailey had studied about half of these tumors, starting in 22 and on to 1924. He primarily used H&E and silver carbonate staining techniques, plus PTAH and a few other procedures that were available. And what he did was he linked various histological types of the tumors that he was describing and diagnosing to the developmental stages of cells comprising the nervous system. And this particular diagram, I'm sure, is very familiar to the pathologists in the audience, at least, because it was Bailey's framework of adapting the terminology of the tumor to these developmental stages. Now, Cushing was renowned for his difficult personality. As a matter of fact, when he was 6 years old, his mother nicknamed Pepperpot. In 1924, a major conflict with Bailey arose. And Bailey found that it was impossible to continue to work with Cushing, and so obtained a Guggenheim Fellowship to study for a year in Paris, which he did in 1925. Before he left, he gave Cushing a preliminary manuscript which he had produced based on about 200 of the tumors that he had already studied. The idea was that in his absence, Cushing would look it over and decide whether he agreed or disagreed or make suggestions and so forth. When Bailey returned to Cushing's laboratory 1 year later, by this time tempers had diminished somewhat, he was absolutely horrified when Cushing handed him a book which had been published by Lippincotts in Philadelphia, entitled A Classification of the Tumors of the Glioma Group on a Histogenetic Basis with a Correlated Study of Prognosis. This was that preliminary manuscript that Bailey had left with Cushing. This is the classification, actually, upon which much of the subsequent classifications of brain tumors have been based. In the meantime, another one of Cushing's students, Franz Ingram, decided that there was something special about the tumors in childhood and went over to the Boston Children's Hospital to establish a pediatric neurosurgery program there. He did this in 1929, and indeed he discovered that there were unique features about the tumors in the children. Now, among the childhood brain tumors, many of which resembled those in adults, there was one group that was particularly troublesome, and they were the embryonal tumors. The embryonal tumors comprise about 20% of the childhood brain tumors and are those which have given those involved with classification the greatest difficulty. Over the years, there developed a changing nomenclature in the classification of these poorly differentiated central nervous system tumors. At first, in the 19th century, very early on, when these tumors were being studied microscopically, they were all called sarcoma. But it became apparent that sarcoma was an inappropriate term, and James Homer Wright in 1910, actually studying the peripheral neuroblastomas and naming them neuroblastoma, also viewed a central nervous system example, and he termed these tumors neurocytoma or neuroblastoma, depending on their degree of differentiation. 5 years later, another pathologist, Vanzetti, gave them a different name, neuroblastoma malignum. In 1918, the name was changed by Ribert to spongioblastoma because it was thought that they primarily were composed of primitive glial cells. 1925, two French neuropathologists gave them yet a different name, neurogliocytoma embryonnaire. And in 1925, Bailey and Cushing wrote a paper in which they described 29 examples of this particular tumor, which at first they called spongioblastoma cerebelli. Then they changed the name to spongioblastoma indifferentiale because Gliomas and Strauss had also described a tumor which actually was a glioblastoma multiforme, but for which they used the term spongioblastoma. So eventually, Bailey and Cushing decided they had to change the name of their tumor, and the diagnostic term medulloblastoma came into use. Subsequently, these tumors composed of undifferentiated neuroepithelial cells acquired a whole host of different names, which are listed here, which I won't read to you. The situation by the 80s had become such a complex and confusing problem that the pediatric oncologists approached a group of pediatricians and those involved in dealing with childhood brain tumors and obtained money from the American Cancer Society to have a seminar dealing with the various aspects of pediatric brain tumors. They selected a group of pediatric neuropathologists to address the issue of the classification of the brain tumors. This group consisted of myself as chairman of the group, Floyd Gillis, Richard Davis, Lawrence Becker, and Peter Berger. We took as the basis for the classification that we were going to propose the 1979 WHO classification, which simultaneously had been worked on by a group of pediatric neuropathologists throughout the United States and Canada, in which a group of 3,300 brain tumors, pediatric brain tumors, had been collected by Dr. Gillis and were reviewed by a group of neuropathologists. Richard Davis and I had the task of looking at all 3,300. And our task was to apply a diagnosis based on the 1979 WHO classification for each of these tumors. The majority of the specimens were stained with H&E. We had no clinical information, and in order to assess our reliability, we looked at 700 of these 3,300 a second time. The major problems that we encountered were with the diagnosis of the embryonal tumors. The problem was that tumors that looked like medulloblastomas occurred in other areas of the nervous system. And when they occurred outside of the nervous system, they were given a different name. If they were in the pineal, they were called a pineoblastoma. If they were in the cerebrum, they were called a central neuroblastoma. But without knowing the location, Dr. Davis and I had no way of applying those names. In the process of reviewing these cases, we also noted that the site of origin was related to the prognosis, regardless of the diagnosis of the tumor, and that the cerebellum was actually the most favorite site of childhood brain tumors. We found the most common tumors in this group, the pilocytic astrocytomas, gangliogliomas, of course the embryonal tumors, malformative tumors such as craniopharyngiomas, choroid plexus lesions, germinomas, germinal tumors, the subependymal giant cell tumors, and subsequently additional specific childhood brain tumors are the superficial dural astrocytoma, the desmoplastic infantile ganglioglioma, and the gliofibroma, among others. When this work was published, we had at the end of the list of diagnoses this category that we called unclassified tumors. And we said a small percentage of the tumors, when examined by standard light microscopic techniques, cannot be placed in one of the above categories. Immunohistochemical methods and electron microscopy assist in defining the nature of some tumors, but a fraction may remain nameless even after all avenues of investigation have been exhausted. Under these circumstances, it seems prudent to provide a descriptive diagnosis rather than to create a novel name. This was published in 1985, at the time when the techniques of further studying these tumors were just coming into use by application of immunohistochemical techniques, and our colleagues in genetics were beginning to look at these tumors in a serious way to determine whether or not they had any particular cytogenetic features that would allow their separation. I'm going to take two of the embryonal tumors as examples of how the classification has evolved on the basis of the use of these special techniques. The first is the primitive neuroectodermal tumor, medulloblastoma, and the second is the ATRT. Now, the medulloblastoma, as I mentioned, was described by Bailey and Cushing in a paper in 1925, where they described 29 of these 400 cases as, quote, a very peculiar tumor of a peculiar kind in the cerebellar vermis of children. They had 5 additional cases, which they said were unquestionably of the same histogenesis, but they occurred in the cerebral hemispheres of the adults. So immediately the problem of the tumors outside of the cerebellum were already apparent. Now, Bailey and Cushing thought the histogenesis of these tumors involved the primitive glial cells, which were called spongioblasts. They then changed the name, as I indicated, to a medulloblast, which was a theoretical embryonal cell with the capacity for differentiating along glial and neuronal lines, and eventually it was thought that the tumors arose from the external granular cell of the cerebellum and hence were specific to the cerebellum. The problem, of course, remained as to what do we do with the tumors that looked like the medulloblastomas but were in other sites of the nervous system. When I was president of the American Association of Neuropathologists, I had to give an address. And this was the whole problem of what to do with the classification of these tumors was uppermost in my mind because I dealt with the problem every day in my work at the Children's Hospital. So I looked at the literature which was then available and determined that because of the fact that there were tumors in other parts of the nervous system that were similar to the medulloblastoma, but which had other names, that perhaps all of these tumors could be put into one category, and we could consider the fact that they all rose from primitive neuroectodermal cells. The name primitive neuroectodermal tumor actually had been introduced by Hart and Earl in a paper a few years before that time, in which they were also grappling with the problem of what to do with the classification of these tumors. This particular photomicrograph is labeled PNET, but it's actually a medulloblastoma. So this is a tumor from the cerebellum. This is one from the cerebrum, which looks very similar. And this is one from the pineal. And you can see the similarity between these and the difficulties that the pathologist had in determining what to call them. The advent of the use of immunohistochemistry then allowed us to determine some of the primary histological or cellular characteristics. And so a variety of antibodies were applied to these tumors, and it was found that they expressed neurofilament protein. A large number of them expressed neurofilament protein, which are the brown stains. GFAP, glial fibrillary acidic protein, in various patterns. Vimentin was oftentimes expressed in these tumors. Retinal S antigen was another surprising antibody that was expressed. Desmin was found in a certain percentage. And even keratin in some of them. So these were tumors that had a capacity to express various cellular characteristics, the actual significance of which we weren't certain at that point. In addition, we did immunofluorescence studies and discovered that there were populations of cells, and those in the upper two, A and B, labeled 1, were stained with both GFAP and neurofilament protein, so there was dual expression in some of the tumor cells of 2 different antigens. In the lower half of the field, the right side is GFAP, and the arrow points to a GFAP cell, and on the left side we have the neurofilament stain. So we had a peculiar situation in which these tumor cells were doing very peculiar things. And this is a table showing the co-expression in individual cells. I'm not sure that we still know what the significance of this co-expression is, but it has been found in brains of children with tuberous sclerosis and in probably other situations. But we tried to associate the co-expression and these various expressions of the antibodies with prognosis, and correlation wasn't very good. At that time, the primary cytogenetic abnormality for the medulloblastoma was an ISO17Q abnormality. Let's go for a moment to the atypical teratoid rhabdoid tumors. Now, there was nothing new about these tumors. That is, this tumor just didn't sort of arise in the 1980s, never having existed before. But I saw my index case in 1985, and it was through the use of immunohistochemistry and the morphology of the tumor that it became apparent that there was something unusual about it. Up until this time, these tumors had been considered medulloblastomas. But as a slide reviewer for the Children's Cancer Group for a number of years, in which I looked at large numbers of embryonal tumors, there was a small group that I could always recognize as something different, because the pathologist, who was originally responsible for the classification, would always write a very long description and would write a comment about, this doesn't look quite right, but this is the best way I can diagnose it, so they would put it into the medulloblastoma category. The problem was that there were fields in this tumor that looked very much like the primitive embryonal tumor. Here's one field that has a nice flexor Wintersteiner rosette. Other areas in this particular tumor that I first saw in 1985 had these glandular type structures. Here's the combination of the rosette-type canals with the primitive-looking cells. Then there was a population of cells that I didn't recognize at all. They were large, they had a prominent cell body, a prominent nucleolus, oftentimes very striking cell borders. And when I showed the tumor to one of my colleagues, a pediatric pathologist, she took one look at it and she said, "Oh, those are rhabdoid cells." Well, I, as a neuropathologist, had no contact with rhabdoid cells because they had been described initially in the kidney of babies. So we now had a component of these tumors with variable features of rhabdoid cells. Some of them had a sarcomatous appearance, as you see here. The immunohistochemical pattern was really quite different from the medulloblastomas. Vimentin was very strongly expressed. Epithelial membrane antigen, which is essentially never seen in medulloblastomas, was also strongly expressed. Smooth muscle actin was also a prominent antibody. Most surprisingly, GFAP was very common in many of these tumors, and in fact, neurofilament protein, and it looked as though the neurofilament protein was being expressed by the rhabdoid cells. Keratin was also found in a number of the cells. In 52 of these cases that we studied, this is the list of the antibodies that we found and the percentage, again, indicating this to be a very different tumor from the medulloblastoma in terms of its oncology and oncocytogenic features. But also, there were some clinical features. It was a tumor primarily of infants 2 years and less, and it explained why the pediatric oncologists used to say that an infant with medulloblastoma has a much worse prognosis than one who's over 2 years of age, because obviously what was happening was that the babies with the ATRTs were being misdiagnosed. On electron microscopy, they had these intermediate whorl-like structures. Dr. Jackie Beagle, who was the cytogeneticist at the Children's Hospital, was doing the cytogenetics on these tumors that we were accumulating, and she and others working on these tumors found that there was a mutation or deletion of both copies of the INI1 gene, which mapped to chromosome 22 in 70% of the cases. And there was a decreased expression at the RNA or the protein level, indicating loss of function event. In the late 80s, I was asked to give a lecture on the subject of childhood brain tumors, and as I was preparing for this lecture, I was going over some of my old lectures, and I came upon this slide in which I made this prediction. Expression of information regarding the role of various genes in the pathogenesis of CNS tumors will undoubtedly lead to revision of existing classification schemes. I think it was apparent to those of us who were working in the field that the entire problem of classification was going to be advanced by our colleagues who were doing this elegant work in the genetic laboratory. This has brought us from the ISO 17Q categories of the medulloblastoma to these 5 categories, which Dr. Lewis discussed this morning. But most interesting was a paper that appeared in February of this year in Cell with this large number of authors, in which a large number of medulloblastomas and PNETs, they included PNETs from other parts of the nervous system, and came up with yet another molecular classification of the CNS PNETs. And this is their classification, which is becoming even more complex than that which we already have. Now we might ask, And I think you all know the answer to this. Why is classification important? Obviously, to know how to treat the patient with the brain tumor and to give us some idea of the prognosis. A clinician never accepts a diagnosis from a pathologist of "I don't know." That is totally unacceptable. So we always have to give a name to a tumor. And if we don't know a name, we make up a name, and this, of course, is what has gotten us into so much trouble. I think those problems are going to be done away with as we go on. So where are we today? I think it's apparent to all of us who have worked in the field of oncology that cancer is less a disease of specific organs, but more as one of molecular mechanisms caused by mutations of specific genes. That, I think, is very clear. Now, the current technology has been to do liquid biopsies to detect circulating DNA. That is, a blood sample is taken and is sent off to the laboratory to determine circulating DNA. The NCI had a trial which was called the MATCH trial, in which these liquid biopsies were sent to a gene testing lab to scan for more than 4,000 possible variants of the circulating DNA of 143 pertinent genes. It was found that the precise genetic identification allows tailoring the best treatment, which may not necessarily be a drug specific for the central nervous system neoplasms. And a paper that was reported at the American Society of Clinical Oncology reported that HER2 used for breast and gastric cancer is now useful for colorectal, bladder, and bile duct cancers. So it may be that the agents that are used for peripheral cancers, if they share genetic features with those in the central nervous system, can be used to treat those children with primary brain tumors. Some years ago, I came upon this, what most people think is a rather hilarious classification of animals by the ancient Chinese. And as you read through the list of how they classified animals, you can't help but chuckle over what their ideas were. It's quite likely that our scientific progeny, looking at the classifications that have held sway over the years, will find them equally funny in terms of the current state of knowledge that we have. So let's look at the long view. Where did we come from? We came from a development of cellular pathology that goes back to the late 1800s and was focused primarily on microscopic examination of tissues and attempts to classify tumors on the basis of their morphological features. We then were able to use special kinds of stains, PTAH for glial cells, silver stains to recognize neurons, and that allowed us to advance to some degree so we could separate out the various kinds of tumors. Then our techniques in immunochemistry allowed us to take a gigantic leap forward to determine the nature of the composition, cellular composition of the tumors. At about the same time, the cytogeneticists began to take a serious interest in what were the genetic features, because of course it had been established that cancer was a genetic disease. And so now we're at the stage where we have a phenomenal amount of information dealing with the combination of the morphology and the cytogenetics. And the question is, where are we going? We're going to go as far as our technology takes us. And at this point, we perhaps cannot even predict where that will be. But the important thing to keep in mind is that we remain open to the basic scientists who work in this field, who establish principles that may not be directly related to brain tumors of children or adults, but who will find features that will assist us in diagnosing and classifying these lesions. So diagnosis and classification will probably no longer be solely in the eye of the beholder and will be a function of the technology which is available. So we should be prepared for those changes that are going to take place, and we hope that they will allow us to diagnose and treat the patients who come to the care of the oncologists and the pediatricians and other adult oncologists to taper and modify the morbidity and the mortality of these terrible diseases. Thank you.